Do you have questions, Roger?
Oh my God.
Fire the questions at us. We've got a bit of time left to talk. We haven't just...
Yeah. We've been going nuts here. It's a really, really simple one, but caused a bit of fury, is that people, Jonathan, want to know what happened with the scrubbing in. Did you get to scrub in?
Yeah, so I think basically it's a lot of massaging at the moment with different people. I think we're working on it. My search term is number 5, so we've got a bit of time. I think in the end, it's really about just people knowing who you are. For example, when I was at North Shore, all the theatre people end up knowing me. It wasn't as though I was just this... I remember one of the first time I walked in the theatre, so I buzzed in and I went in. The theatre manager, she's like, "Are you a patient?" Like, and I was like, "Oh no!" I showed her my badge, and I had to. I think it was some gynae procedures I had to go in, but it's just stuff like that. I think once people know you, then they understand what you can do, and you're not just a foreign person. People at RPA have actually been quite lovely. The culture there is quite supportive, and I think once people start knowing you, then they're really happy to help.
Yeah.
Okay, thank you. I guess this is a question that really goes out to the entire panel, but maybe to Jean-Frédéric somewhat, is the barriers to physician uptake of telehealth. Because I think to some extent, all of us, I know when I was listening into you guys talking the other night, I was surprised at how keen you were on telehealth, because we all hate Zoom, and yet you've given us a compelling reason for why it's really useful. And I wonder what you think the physician uptake barriers are.
Now, don't get me wrong, we love shaking the hands of our health professionals, but not at it's weighing that up between, it would be nice to see you face to face, but actually I can't waste 3 hours of my day doing the trip to that if actually all you're going to do is look at my blood work today. So too bad. I'll see you in person next time when you have to touch me. But yeah, do you want to answer the question?
I mean, the experience, COVID has been so disruptive, but the reality is that everybody had kind of to default to a replacement solution. Let's all go on the telephone, or let's use Zoom to see some patients, etc. But the groundwork to make this work for clinicians as well and embed it in clinical practice needs to be done. We need triage tools to identify what are the consultations where virtual care will work, and what are the types of consultations where it wouldn't. And then we can engage with patients and give a choice, but also provide the right argumentation about why a face-to-face consultation is really relevant now. The evidence in the literature is clear. There's a lot of benefit of virtual care, not just in terms of the patient experience, but also in terms of clinical quality of care. There are things that work really, really well in virtual situations, and for some subgroups that have tended to be stigmatized and for whom access to healthcare may be a challenge, virtual care was providing a safe space. So we need to learn about that and work with clinicians so that it works out. But you're right to say that, and we've had many clinicians come back to us to say, "Oh my God, this is not working because, patients forget their appointments. I go on Zoom and I wait forever. I don't know. I thought my next patient was face-to-face, but not, and it's clunky at the moment." So we really need to work to, again, redesign what is an outpatient clinic so that we can really harness those technologies in a way that will fit into clinical practice. Because let's be honest, every clinical encounter is a partnership between a patient and a clinician. And the patient needs to be really driving the way we design healthcare, but without ignoring how it will fit with providing good, safe clinical care. And we've got a lot of work to do. So that's why we're investing in a virtual care accelerator with eHealth in New South Wales, really working on all of the different aspects of delivering healthcare and try to revise the way we work, engaging patients in local areas to build pilots and new ways to work.
How are consumers involved in that process?
Well, there's methods for that. I'm really a science person. That's why I said a bit nerdy in my
We're all
introduction.
Scientists, though, in medicine and healthcare.
So there's a lot of science around it, and there's also a lot of learning about how to use those tools. co-design is a method that we can really use in many different areas. We can also really make sure that we go more broadly to a broad range of people and really try to understand what are the most common problems, etc., and then create that space where clinicians and patients can work together at designing a solution. And our role at an agency like ACI is to really be the facilitator of that process, so that when clinicians and patients agree, we move on, and when they disagree, we try to find out why, and then build something that will create a jointly owned solution. But it's a lot of work.
Yeah.
It's a lot of time. It's a lot of effort, and we need to do it in a rigorous way, and in a way that is also respectful of everybody's expectations. And that, so we're learning to increasingly use these co-designs approaches in healthcare system redesign.
Yeah, and I think we can't forget that all of this rapid telehealth implementation happened in the middle of a global pandemic. Like, I've been providing telehealth appointments and receiving them, and it's been the most stressful time that most of us have ever experienced. So the experience, like, it feels almost like you can just, we hate Zoom because we want the pandemic to be over. I think there's an element of that, and people haven't had the brain space to learn and the cognitive capacity to learn all of these new ways of doing things whilst there's such high level of stress and uncertainty and everything going on for patients and clinicians. I'm going to stop there because I've got a lot to say about that, but I'm not going to. Do you have another question?
Yeah, I've got stacks of questions. There's perhaps another simple one to the group, which is, in terms of research design, how do researchers access the consumers in a way? I guess that there's a bit of uncertainty as how do you go about getting people's voices?
Okay.
Yeah, so I'll answer that one because I'm actively involved in research, and that's a great question to whoever put that in, because research or co-design has to start from the top. So you have to involve people with lived experience right from your protocol. So when you're submitting ethics, you have to have a consumer involved, because if you don't have that involvement at the start, then the whole design process is about what the clinician wants, not really what the consumer wants. And so,
not just about wants, right? It's like, how is this solution going to work to deliver better health outcomes?
Yeah,
and
exactly.
if you don't define what the outcome is supposed to be in consultation with the consumer or the patient or the person, then you're really just going to them to get a check. Like, do you think this problem that we've solved is going to be good?
Yeah, exactly. And so to answer the question of how to involve consumers, there are actually lots of consumer groups out there that, whether it's autism, whether it's multiple sclerosis, whether it's spinal cord injury, that do have active involvement. And so if you involve those agencies at the start, they can direct you in how to best involve lived experiences in your research.
Or employ them. So, part of my job is I work in recruitment. So I involve patients in stroke research. I look for participants and I help trialists kind of design their recruitment strategy. And in doing that, when we started this project and I was tasked with it, I really, the job description was find the participants for the trials. And just, go spend more time in hospitals and you will find them and then they will participate. And it very quickly was clear that that wasn't going to work. And where it did work, without kind of the redesign of the whole culture around this platform, where it did work was where I had existing relationships with people who live with stroke. And not just friendships, but also we need to actually just accept the skills and lived experience of people as expertise that's needed in a team. So if you're organising a project, you need to make sure that you involve people with the relevant expertise, and that includes lived experience, it includes clinical experience, it includes health manager experience, depending on what the project is. So I think you kind of also just need to know people and have relationships with people. And if you work with people with lived experience that's relevant, that's way easier, because at least you've got a starting point and you get to know about the things that are, this kind of culture stuff around disability. Disability culture is something that I didn't even really know existed. But yeah, I think employ us and then seek out members of research teams that are going to have the expertise that you need. Were you going to add something?
Oh, I just agree with you. I think that there's so much knowledge that we can learn from patient experience, clinicians' knowledge, and the new technologies of virtual care, but also telecommunication, etc., are really helping many research projects to have that added component to it. There's lots of virtual care trials going on at the moment. It's a world of possibility.
But we probably could run a workshop on consumer involvement in medical research. And to me, I've run workshops in this space, but the most important things are kind of breaking down the power structures when you're working within a research team. And most of us are used to having a patient doctor or a patient-clinician relationship with consumers. And that doesn't work if you're working together with someone as part of a project team. So kind of your approach to working with people needs to be different there.
And not be afraid to engage, because just because someone has lived experience doesn't mean they may have other experiences too. So they may be a researcher, or they may be they work in other fields. The importance of involving lived experience is that you can design a trial that will actually fit with the lives of the people you're trying to investigate. So a great example here is in spinal cord injury. If you're going to make appointments for whatever reason, don't schedule it in the morning when they're doing their morning routine, because it takes a while for them to get up. So, just simple things like that can, if you have consumer input, that makes it so much easier for you to design a successful trial and have the patient numbers to be significant.
If I can share an example, I recently did a story about how people with disability are really dominating the tech space at the moment. There are so many startups and accelerator programs where people with disability are at the forefront of creating assistive technology, and traditionally that assistive technology has been designed, manufactured by non-disabled people for many, many years. And it now is this really big, exciting thing that people with disability are designing our own technology, but you sort of stop and wonder, why wasn't that happening the whole time? If you're non-disabled and you're designing technology that you don't even necessarily need to use, how do you know what we need? That's the best way to sort of look at it, I think.
Yeah. Roger.
Still going? Wow. So exciting. I guess there's a couple other questions that have identified the sort of gap or accessibility to diagnoses, particularly for chronic health conditions. So I think it's maybe particularly relevant in the pediatric world, where there's a couple of people saying, what can we do to address that accessibility where you often have to wait months for sort of chronic healthcare appointments and things too?
So specifically the question is about how do we
narrow the gap and make the sort of diagnosis and seeing clinical help faster, because it sounds like there's a lag often in establishing diagnoses and things because people have to wait months for appointments.
Okay.
Well, I can just re-emphasize the two areas of work that I talked about today. If we have a more routine assessment of people's quality of life as part of clinical consultation, we will unearth problems earlier for patients, and that will support early diagnosis. And virtual care is not just for that, clinician-patient interaction. There's a lot of clinician-to-clinician interactions that can be harnessed through virtual consultation and in-reach program, so that we support primary care, we support generalists working in rural areas, and increase capacity to address some of those problems despite the allocation and physical distance problems that we're facing. And another thing I would like to emphasize is that those technologies help also patients to connect together. And to a great extent, that's an area that's really evolving and developing, and we need to harness that as well. There's a lot that can be done through peer support, not for everything, but certainly in many healthcare conditions, we need to make sure that that virtual technology is available for groups of patients that want to create that connection and that peer support.
I was reflecting on that as well. I mean, I've got a genetic connective tissue disorder, Ehlers-Danlos, and the wait for a diagnosis and the wait to see a geneticist in the first place is extraordinarily long. I got my diagnosis when I was 20, I think, and I'd had lots of problems beforehand. But many people aren't being diagnosed until they're adults, and are being kind of told just that these things are normal growing pains. But what you made me reflect on was the interesting environment that it is being in online patient support groups, and then some of the stigma that comes around that when you might bring new information to a health appointment to say, well, look, actually other people who are in this support group have said this about a treatment. And especially when someone comes to you talking about a treatment that really isn't based in any science, the way that you react to that as a clinician can actually cause some access barriers for people. If you react and think, oh, what have those unskilled people been telling you in your group, that's not going to work, and you're not open to understanding all of the knowledge that patients have together about what it actually is like to live with the condition, like that's a big problem. And perhaps people, because they are waiting so long to receive medical care and diagnoses, they're turning online. Of course, of course we are.
Absolutely.
I think another thing that I would point out is the importance of early intervention as well. I mean, I have a secondary condition. Oh, we don't rank these things, but apart from my vision impairment, I also have a neurological condition which affects my ability to read Braille. I have a lack of sensitivity in my fingertips. Now, I struggled to read Braille for basically my entire primary school education. I was falling behind incredibly quickly, and I had this support teacher who kept saying to my parents, no, she's just really lazy. She just needs to keep practicing. Don't make excuses for her. She needs to just go home every night and she just needs to read and read and read. And it wasn't until I was about 9 or 10 years of age where I was actually taken to a neurologist and diagnosed with the condition. And it was actually really exciting because I finally had this reason for why something wasn't working the way everyone perceived it should. But also it meant that we could come up with new strategies. And, that could have happened so much quicker, I think, if I was listened to and if there was a bit more sort of monitoring and evaluation. And there's a lot of research around this particular condition that I have now, but at the time there really wasn't. It was quite new. There wasn't a lot known about it. But I think listening to patients is obviously one. And this is all of the understanding that you guys are incredibly busy. You're trying to see huge numbers of people each day. We get all of that. But I think, for me, it was this particular teacher who didn't listen. But I think just taking that into account is really important.
Absolutely. Yeah, and actually I have a smaller subgroup of my online support group, which is 3 women who I had immunoglobulin infusions and sat in the same room as every 3 weeks for 10 years. So we know each other really well. And we do like a little 3-way huddle before any of us has a medical appointment, just to cross-check, is this a symptom or is this something I should talk to the doctor about, or can we sort this one out on our own? There's huge value in connecting people and valuing that lived experience knowledge. So whatever also makes it easier for us to come to a medical appointment really prepared so that we can efficiently get to the main problem. But look, we're going to need to just very quickly sum up. If you've put more questions on Twitter, I'm going to have a great time on the train on the way home looking through them and trying to answer them. Please kind of get in touch through socials with us because we'd love to continue this conversation. My closing word is please think of healthcare convenience as an access issue and think about how do I logistically make this easier for everyone. What's your take-home message, Jono?
So as I said before, normalising disability is something which I think we should aim to do, whether it's normalising with your patient, normalising in the workforce, because basically, as we said, 20% of Australians have some sort of disability. And so if we're excluding 1/5 of our workforce, then that's a whole lot of people that brings in a lot of skill that could otherwise give us a better healthcare outcomes. So challenge yourself. If there are some people with disability, go and have a chat to them, have a talk to them. We're not afraid. We don't get upset if you ask us about our disability.
Unless it's like awful personal questions.
Yeah, or unless, you know, do it at an appropriate situation, obviously. But rather than assume, I think having that conversation is my take-home message.
Short take home in 20 seconds.
I think we need to get out of our zone of comfort as clinicians and really embark on the redesign journey. We've just seen that we can do it in the last few months, and now we can structure it so that it's sustainable for the future, both in terms of virtual care and patient-reported measures, so that we provide person-centered care for people.
I love it. And Naz, you can have the last word.
Listen, learn, consider new perspectives, and know that you're not always going to get it right, but please, wherever possible, ask and just be interested in knowing more about each individual patient.
Thanks so much for having this discussion with us. Gonna hand over.
That was a amazing session to just be a part of, and thank you all so much. I think a confession to the panel is that as a conference organiser for 30-odd years, I've just never really thought about accessibility until this last few weeks, and particularly Jill, because of you and Jessica. You know, it's really going to change the way we look at how we do business and the questions we ask, rather than waiting for people to tell us they've got an accessibility issue. We'll be asking, how can we help? How can we make ourselves more accessible? So on that note, thank you all. Amazing panel.